very low level of evidence. All right, so to summarize, individuals who FeNO testing might be useful include 5 years or older with uncontrolled asthma or current taking inhaled corticosteroid or an ICS-LABA combination, montelukast or omalizumab, individuals whose symptoms indicate that they might require additional anti-inflammatory therapy, individuals with atopy, especially children, individuals whose asthma is being treated by providers who agree that frequent assessments over asthma control over the course of the year are warranted. So in other words, if you're going to use it to monitor asthma and you can only do it in your office, you're going to have to see them frequently to make that assessment useful. I found this buried in the report, which kind of shows you that there really are still quite a lot of, in spite of their tempered enthusiasm, there's still, it's not that great, I'll be honest. So let's, this was to what they said. Let's say you decided you're seeing a patient and there's a 60% pre-test probability of asthma. Well, if you do the test and their FeNO is high, like greater than 50, then the probability afterwards would be about 81%. If the test was negative, it would drop to 30%. So, unfortunately, that neither one of those is something you would necessarily hang your hat on. Now, if your pretest probability was 80% on the bottom half of this slide, that would go up to 92% if with a positive test and down to 54% with a negative test. So again, it's helpful, but not exactly, a truly good diagnostic test. All right, next we're going to talk about allergen mitigation. I think everybody said we should do allergen mitigation, but now we're going to go into a lot of more detail. It turns out that evidence for single interventions designed to reduce indoor allergen exposure on asthma outcome is lacking. But multi-component interventions that bundle more than one strategy may improve some asthma outcomes, but it's unclear which combinations are more effective than others. However, multi-component interventions that include a HEPA vacuum or pest control reduce exacerbations and improve quality of life. And the evidence for single and multi-component interventions does not address many other important outcomes, including asthma-related healthcare utilization, pulmonary physiology, and I can't read my words because they're behind your picture. Let's see if I can, oops, all right, the picture disappeared. Did I disappear? Can you see me?
Yeah, we see you.
Oh, good. How do I look?
Great.
Yay. All right, so these are the different allergy mitigation strategies that they studied. And an acaricide, which is something that kills mites and other insects, they basically said that there isn't enough evidence to make a conclusion on. Impermeable pillow and mattress covers. They basically said that intervention makes no difference. That was studied in a couple of New England Journal articles. That's why they were able to give that a moderate certainty of evidence. Carpet removal. They said that there's not enough evidence. Integrated pest management. They said that the evidence certainly favors intervention as long as it's part of other strategies. Air filtration and HEPA purifiers. Can you see my arrow, by the way?
Yes.
Oh, good. That intervention seems to make no difference. HEPA vacuum cleaners, they said they couldn't comment on, although as part of a multi-intervention strategy, it seemed useful. Whoops. Cleaning products, there was no evidence. Mold mitigation, as a single strategy, no. As part of a multi-component strategy, maybe yes. And pet removal, there's not enough evidence either way.
Except cats.
Okay, so in individuals with asthma who do not have sensitization to a specific allergen or who do not have symptoms related to a specific allergen, the expert panel recommends against allergen mitigation strategies. In individuals whose asthma have symptoms related to allergens confirmed by history taking or allergy taking, the expert panel conditionally recommends a multi-component specific intervention. You can see the evidence is not so great. In individuals whose asthma have sensitization or symptoms related to exposure to pests, the expert panel recommends the use of integrated pest management alone or as part of a multi-component allergen-specific intervention. And in individuals who have sensitization or symptoms related to dust mites, the expert panel conditionally recommends impermeable mattresses or pillows only as part of a multi-component strategy, not as a single component intervention. All right, so this is probably the most important part of the talk, and that is the use of intermittent inhaled steroids. So in patients 12 years or older with persistent asthma, using inhaled steroids intermittently may be as effective as using them as a controller medicine, and using an inhaled steroid and a LABA together as controller and quick relief therapy reduces asthma exacerbations compared to using inhaled steroids alone or with a LABA as a controller. So that's important. We're going to spend a lot of time on this. This is what we call smart therapy. I think one of you did a journal club on this a year or two ago, but this has now become really integral to both the GINA guidelines and the new NHLBI guidelines. And so I think we have to be very familiar with these recommendations. All right, so in individuals 12 years and older with mild persistent asthma, the expert panel conditionally recommends either low-dose inhaled steroids and as-needed short-acting beta agonists for quick relief therapy, or as-needed ICS and short-acting beta agonists used concomitantly. And they said there's conditional and there's moderate evidence. I actually wasn't able to, I wanted to go show you some of the evidence for that. I wasn't able to find it easily, but it must exist somewhere. I know that we're actually studying that here at Northwell. Ramon is doing a study with AstraZeneca looking at a combination product of a short-acting beta agonist and an inhaled steroid. But at least for the guidelines and for the United States, where those products don't exist, they're basically saying, you know, if you give somebody with mild asthma a short-acting beta agonist and you think they need more than that, you could either give them an inhaled steroid to use regularly, or you could just tell them to take an inhaled steroid at the same time they take their short-acting beta agonist. Okay, here's the next slide. In individuals 4 years and older with mild to moderate persistent asthma who are likely to be adherent to daily ICS treatment, the expert panel conditionally recommends against a short-term increase in the ICS dose for increased symptoms or decreased peak flow. So they're basically saying that although intermittent inhaled steroids are good, just increasing the dose of a regular inhaled steroid for patients who are doing just a little bit worse doesn't seem to help. There's a number of articles that have shown that. Okay. In individuals ages 4 years or older with moderate to severe persistent asthma, the expert panel recommends ICS formoterol in a single inhaler used as both daily controller and reliever, compared to either higher dose ICS daily controller and SABA, or same dose ICS LABA and daily controller and SABA. And this is the only recommendation I saw in the whole thing where it was strong and high. So they all really felt this was important, and they all felt that the evidence behind it, which we're going to look at, was very strong. By the way, anybody gets confused, just pipe right in.
How often are you supposed to do the inhaled the inhaled ICS as needed?
So they didn't get into a lot of specifics in these guidelines. They do in a chart that I'm going to go through later. So GINA and NHLBI are a little bit different. Part of it has to do with different formulations that are present in Europe and in the United States. I mean, obviously, if we're talking about an ICS for Formoterol, we're basically talking about Symbicort, because there really isn't any other that there might be one other, but both basically they're talking about Symbicort. So it's either Symbicort or I think what's that other one? Can't even remember the name of it. But anyway, but they have different formulations. So in Europe, they have a dry powder inhaler version. In the United States, all we have right now is a metered dose inhaler. So in the fine print in these guidelines, they basically say you can do it whenever you need to, but you shouldn't do it more than 12 puffs a day.
So John, the
Yes.
behind this is that if you need it, let's say a lot in the beginning for a few days, you eventually titrate to the dose that you need. And when
Yes.
your symptoms are controlled, you shouldn't need it as often.
Right. So that's the theory. I mean, the whole theory behind this is that asthma isn't just this steady disease.
Right.
It's an inflammatory disease that, varies. And you don't want to give patients more than they need when they're having little symptoms, and you don't want to give them less than they need when they're having more symptoms. So by letting them sort of titrate their own therapy, they're actually going to target their therapy better than we could ever do as physicians. And the data seems to suggest that that's true. And we're going to go over some of that data.
This seems like a lava.
Right. Well, that's one of the issues that you might have questions about, was why would you use a 12-hour long-acting beta agonist as needed? Aren't you going to bunch it up and create problems? But at least in some of these studies, that didn't seem to be a big issue. But that has led to a bunch of companies, including AstraZeneca, to start studying combination ICSs with short-acting beta agonists, because it kind of does seem to make more logical sense. But the data for those studies is not there yet.
Overall is one of those that starts acting quickly, right? Even though it's a long.
Formoterol is very quick acting, yes. So that it really is the only quick acting, long acting beta agonist. So that's why both the GINA guidelines and the NHLBI guidelines specifically recommend that combination with Formoterol, and not with salmeterol, and not with the one in Brio, which is the name is escaping me. All right, in individuals aged 12 years or older with moderate to severe persistent asthma, the expert panel conditionally recommends ICS Formoterol in a single inhaler, used both as a daily controller and reliever, compared to a higher dose ICS as a daily controller and a SABA. So basically they're saying this SMART therapy, which stands for single maintenance something, I can't remember, single maintenance and reliever therapy, SMART therapy, is smarter than the way we've been doing it in the past. So here's two of the bigger articles that have looked at this. There was a third article in the New England Journal, but it used inhaled terbutaline as the short-acting reliever, so I didn't think it was as pertinent. But these two trials basically compared budesonide Formoterol to either budesonide regular or just short-acting beta agonist in mild asthma. And in this trial, patients with mild asthma used albuterol alone, inhaled budesonide plus albuterol, or an inhaler containing budesonide and Formoterol as needed. And both, not surprisingly, both groups that got the budesonide did better than the patients that just got albuterol. But if you look at the chart on the right, the patients that got the budesonide Formoterol as needed had less severe exacerbations than either of the maintenance budesonide or albuterol groups. And that was what, I mean, that one group in these patients is really what has shifted the expert's opinion to that this maintenance, this smart therapy might be a better way of doing things. So this is, it's not as easy to see, but time to first exacerbation. Again, if you're just looking at exacerbations, the two budesonide groups did better than the albuterol group. But if you're looking at severe exacerbations, it's only the SMART group that did better than the other two. And this was another article basically doing the same thing.
I'll just cancel the NPR.
And they didn't really get as strong results in this article, but when you put the three articles together or the two articles together, what you see is basically less severe exacerbations. And another sidelight is that the patients who use SMART therapy actually end up using 1/4 of the total inhaled steroids as the control group. So you get better results with less inhaled steroid. Now, one of these days, I'll give you my opinion about all this, which is really not as strong as all these experts. But I don't want to bias you, because for the boards, this is definitely going to be on your boards, and it's definitely going to be. I want you to understand that this, both international and now our national experts feel that SMART therapy is the way to go.
So your response is yes.
All right, so then they talked a lot about LAMAs, and the key points about LAMAs when added to patients with uncontrolled persistent asthma is that when added to inhaled steroids, it reduces exacerbations and improves lung function. And when added to inhaled steroids and LABAs, it improves asthma control and lung function. But I should just add with a big comma, it does not reduce exacerbations. Okay, so in a group that's not getting LABAs, it improves exacerbations and lung function. In the group that gets inhaled steroids and LABAs, it improves control and lung function, but not necessarily exacerbations. There's a trend, but not statistically. So going into a little bit more detail, in individuals ages 12 years and older with uncontrolled persistent asthma, the expert panel conditionally recommends against adding a LAMA to an ICS compared to adding a LABA to ICS. So even though LAMAs work, the data favors LABAs over LAMAs. If a LABA is not used, then the expert panel does recommend adding a LAMA to ICS. And probably most importantly, in ages 12 and older with uncontrolled persistent asthma, the expert panel conditionally does recommend adding a LABA to an ICS LABA compared to just doing nothing. Okay, so this was surprising to me, but again, we're not going to take away all my biases, but they basically came out strongly in favor, not strongly in favor, but in favor of subcutaneous immunotherapy. Subcutaneous immunotherapy reduces use of long-term controller medicines. It may also improve quality of life of an FEV1 and reduce the use of quick relief medications and systemic steroids. Sublingual immunotherapy improves asthma symptoms, quality of life, and FEV1, and reduces the use of long-term asthma medications. And I don't understand this, even though this is a key point, they come out against the use of sublingual immunotherapy. Local and systemic reactions to sub-Q immunotherapy and sublingual immunotherapy are common, but infrequently require change in treatment. Life-threatening events are reported rarely. However, just because of number 3, we're going to talk about this, I think, in another slide, they recommend against immunotherapy in patients with severe asthma. Okay, so it's only for mild and moderate asthma. Okay, so in individuals aged 5 years and older with mild to moderate asthma, the expert panel conditionally recommends the use of sub-Q immunotherapy as an adjunct treatment. in those individuals whose asthma is controlled at the initiation, buildup, and maintenance phases of immunotherapy. So why they added this little caveat at the end is they don't want you to start immunotherapy to patients who are uncontrolled because of the dangers of possible anaphylaxis. So again, you don't want to give it to severe patients, and you don't want to give it to uncontrolled patients. In individuals with persistent allergic asthma, the expert panel conditionally recommends against the use of sublingual immunotherapy. So I really have no idea why they put in the key points that it works, but they're against it. So I just can't figure that out. Maybe I put in a typo, but they're definitely against sublingual, but they're for subcutaneous. Okay, so then the final topic is bronchial thermoplasty. And basically, bronchial thermoplasty, along with standard medical management compared to medical management alone, may improve asthma control and quality of life, but the evidence is insufficient to determine impact on asthma exacerbations. So that seems like a qualified yes. Bronchial thermoplasty with standard management compared to similar procedure without the heat does not improve asthma control or hospitalizations, but may reduce severe exacerbations in ER visits. It seems to be contradicting to the first one, so I don't understand that, but I don't know. Bronchial thermoplasty causes more adverse events during the treatment period than standard treatment. Based on the available literature, there is still uncertainty about the balance of benefits and harms and about which patients are more likely to benefit from the procedure. So this was a lot of gobbledygook talk. So what do you think are they recommending yes, no, or maybe?
Seems like
I'm
a
not
maybe.
sure. Yeah, it's a big maybe, I think. So here's in a little bit more detail. So in 18 years and older with persistent asthma, they're recommending against. But then in 18 years or older with persistent asthma who place a low value on harm and a high value on benefit, you might consider it.
Risky patients.
Yeah, well, I guess a severe patient who likes to take risk and not so worried about harm. Okay.
Because they really understand.
All right. So now this, I'm going to end up talking a little. Well, actually, no. I have to talk about one more topic because Dr. Iakov was making it. So, but these are the chart. This is the chart based on the NHLBI guidelines, and it's kind of strange. So, and it's a little bit different than the GINA guidelines. So I want to highlight the differences. So basically, the American guidelines, the NHLBI guidelines still believe in intermittent asthma. The GINA guidelines have says there is no such thing. We shouldn't be using PRN short-acting beta agonists at all. Kind of interesting. The NHLBI guidelines as step 2 recommends a PRN concomitant ICS and SAVA or a daily ICS and PRN SAVA. The GINA guidelines don't really have this step. So the guidelines, they basically took the data and came up with different stepwise approaches. So we'll just go through this first, and we'll go through the GINA second, and you kind of have to remember the differences if you're going to get the test questions right. That's why I made your pretest, so that you get them all wrong, because they're kind of confusing. So step 3, daily, Step 3 for the NHLBI guidelines is daily, so that means regular, plus PRN combination ICS formoterol. So they go from a step 2, where you're taking a SAVA and an ICS, to step 3, where you might be taking a low-dose Symbicort twice a day, plus Symbicort as needed. Then step 4 is a daily and PRN combination medium dose ICS formoterol. Now the problem though is that I'm not sure what they mean by medium. So I guess since there's only 2 formulations in this country, this is 80 and this is 160. So from step 3, you go to step 4, which is daily, which I assume means Symbicort 160 twice a day. And then, and then Symbicort, I'm trying to, my arrow goes to sleep if I don't keep shaking it. And then Symbicort as needed, okay? And then step 5, you would add a LAMA to that. So you would have the daily twice a day plus a LAMA and a PRN SABA. Now in the United States, although it's not approved yet for asthma, that does exist as an inhaler. They're called Breztri, or you could theoretically give 2 different types. So you could give Trelegy, which is Glaxo's version of an ICS LABA-LAMA, but then you would also want to give a PRN SABA. So they switch. So if you notice, I didn't even notice that until just now. So now once you add the LAMA, you're no longer giving a PRN combination, you're going back to a PRN SABA.
That's
And then
fascinating.
now why they do that, I have no idea. But that's in the guidelines, so that's what you would recommend. So for step 5, you could either use Breztri plus albuterol or Trelegy plus albuterol. Those are the 3 combinations, or you could do it as separate products. And then step 6 is even stranger because now you're going to a daily high dose ICS LABA plus oral steroids, plus a PRN SABA, and they get rid of the LAMA because they don't think the evidence exists for step 6. Okay, everybody got that down straight? Because it does make for good, even though it's a little strange, it makes for good test questions.
Mhm.
All right, so these are the GINA guidelines. So the GINA guidelines, like I said, step 1, they still have a step 1, but it's really a step 2 or 3 in the United States guidelines. So step 1 for the GINA guidelines is as needed ICS formoterol. There's never a step where they would use a SABA. In fact, if you notice, their preferred reliever all the way through step 6 is ICS formoterol. So unlike the US guidelines, which go back to a SABA for steps 5 and 6, they just keep the ICS formoterol for all their steps.
Huh.
Okay, so another difference is that for their step 1, which is similar to our step 2 or 3, they use just as needed ICS formoterol without a regular dose. Okay, so then they up it. So step 2 would be a daily low dose ICS or as needed low dose ICS. So they're still doing PRN. Well, these are considered equal. So either a regular ICS or PRN ICS formoterol. So by this step in the US guidelines, we would have been using regular ICS formoterol plus PRN ICS formoterol. So differences in these steps. The truth is this mimics the New England Journal study. The US guidelines don't. Step 3 is a low dose ICS LABA. So this now it's regular with an as needed ICS formoterol as rescue. Step 4 is so here they're saying they don't want to give AstraZeneca a full monopoly on the full therapy. So theoretically, you could be giving, Brio in the 3 different doses in steps 3, 4, and 5 as maintenance, and Symbicort as reliever, which sounds very confusing, but that's what they wrote.
And we'll
And
cover it, right?
what?
The insurance is not gonna cover two.
Yeah, the insurance, the pharmacists, I mean,
Right.
nobody is ready for that. So
Right.
yeah, if you prescribe Symbicort and Brio at the same time and tell the patient to go get that at their local drugstore, I mean, your nurse practitioners are going to be pulling their hair out because it's not, none of this stuff is FDA approved. And then for step 5, they basically say that's when you could add your LAMA, you could add a biologic. They kind of just put them all into one group. All right, so for safety reasons, although I'm not sure what the safety is, GINA guidelines got rid of SABAs for step 1. The US guidelines still believe in SABAs for step 1. GINA now recommends that all adolescents and adolescents with asthma should receive symptom-driven or regular low-dose inhaled steroid controller treatment to reduce the risk of serious exacerbations. And so they basically said there's no such thing as intermittent asthma. All right, so they're the only ones that talked about biologics. So I did want to at least give, although I'm running out of time, my voice is getting hoarse, but I figured one slide on biologics. Rather than go through a lot of detail, I just wanted to kind of mention that there is a lot of overlap between all the biologics. So although they have this slide which says maybe you should use an anti-IgE, an anti-IL-5, or an anti-IL-4R. So basically this is omalizumab, this is mepolizumab or benralizumab, this is dupilumab, and then this would also be reslizumab. You're going to see that which one you're going to pick is going to be dependent on a lot of overlapping factors. So certainly the anti-IgE, if they have to have high IgE levels, they have to have allergen-driven symptoms. For the anti-IL-5s, they have to have high bloody eosinophils. But you're going to find that high bloody eosinophils predicts a good response to all the biologics. So right now, the only one that's FDA approved for nasal polyposis is dupilumab, but there's data for both omalizumab and mepolizumab and benralizumab that's going to be coming out. So basically, choosing a biologic is not very simple, and that's why there's a lot of these overlapping things. And that should help you get the answer to one of my last slides. All right, so Anna Maria wanted me to talk about allergic aspergillosis. So my last few slides are going to be a lot about that. It's mostly in patients with cystic fibrosis or asthma. The prevalence in both of those is about 13 and 9%. There's different radiologic classifications, so it makes for good test questions because they have all these radiologic. So there's ABPAS. They basically have normal X-rays, but they have serologic and clinical features of allergic aspergillosis. ABPA-B, they have it plus bronchiectasis. ABPA-HAM, high attenuation mucus. I'm going to show you a picture of that. And ABPA-CPF, which is, kind of end stage bronchiectasis with fibrosis. So that might look like this. You can see pretty bad fibrosis, central bronchiectasis. This is the finger in glove sign. I've never understood this. So if somebody can explain to me why doesn't it not called just a finger sign? To me, it looks like a bunch of fingers. Why is it a finger in a glove? I'm opening this up to discussion. Because I've heard this term since I was a medical student. Why is it a finger in a glove? How do you know there's a glove on? Does anybody know?
It's white, I don't know.
It's like Michael Jackson. There's the white glove on the
It's
right.
a white glove. All right, I'll go with that. Because I just thought maybe there was something I was missing. All right, so maybe because it's a white glove. Okay. All right, so here's ABPA. You can see that it can just be a little bit of ABPA, a moderate amount of ABPA, or a lot of ABPA, so it can cause even bad cystic bronchiectasis. Here's an example of hyperdense mucus. So you can see it almost looks like the same radiologic density as bone, if you look at the bone windows. And that's supposed to be fairly specific for this disease. And these make for great test questions. You're going to forget this as soon as this talk is over, but at least I've covered it. You can get, I'm happy to share these slides for anybody who wants them. There's 3 different classification for this ABPA. One is called the ISHAM criteria. You have to have either bronchial asthma or cystic fibrosis, and then you should have both evidence of type 1 hypersensitivity, which would be an Aspergillus skin test or elevated IgE levels against Aspergillus, plus elevated IgE total greater than 1,000. And then 2 of these 3 things, the presence or precipitating or IgG antibodies, radiographic pulmonary opacity is consistent with ABPA, or if a total eosinophil count is greater than 500 and they meet everything else, then that might be good enough. It's very confusing. Then there's the Rosenberg-Patterson criteria. So they have major and minor criteria. I've already forgotten how many of each you need, but oops. So you have to have asthma, presence of transient pulmonary infiltrates, immediate cutaneous reactivity to Aspergillus, elevated total serum IgE, precipitating antibodies against Aspergillus, peripheral blood eosinophilia, elevated serum IgE and IgE to Aspergillus 8, central and to Aspergillus and 8, central and proximal bronchiectasis with normal tapering of distal bronchi. And minor criteria, brownish sputum plugs, positive sputum culture, and late skin reactivity to Aspergillus. And then finally, there's the Cystic Fibrosis Foundation, which just pertains to patients with CF, who you're trying to diagnose ABPA. And they say if they have a deterioration in cough, wheeze, sputum, and an elevated total IgE of greater than 1,000, or Aspergillus with Aspergillus precipitans, or increased Aspergillus-specific IgG or IgE, and new infiltrates on chest CT, chest X-ray, or CT scan. Treatment includes steroids. Don't ask me the dose or the duration. It's not really worked out. The guidelines mostly suggest itraconazole, but then it seems like there's been a switch to more people recommending voriconazole lately because of its better pharmacokinetics and pharmacodynamics. Omalimumab has been tried in small trials and been shown to be helpful. And there's case reports with mepolizumab and inhaled amphotericin. All right, to sum it all up, exhaled nitric oxide is somewhat useful. Intermittent inhaled steroids are good. Allergy avoidance is good, but only if comprehensive. Immunotherapy sub-Q is good, but again, don't do severe patients and don't do it on patients who have poor control. LAMAs are somewhat helpful, but not for exacerbations. Biologics are useful, overlapping, and ABPA is very confusing. Any questions? Do you guys want to go over? Do you have any questions about the pretest? Did anybody look at the pretest?
So John, the whole concept of getting control and then scaling down therapy?
That's not in any of those guidelines. It's not in those guidelines. There is something about how you shift things around in the GINA guidelines, but it doesn't. The idea that we used to start high and then step down,
Right.
they don't really recommend that anymore. But they do recommend constantly reassessing. So you start based on what you think is necessary, and then you step up or step down based on how they're doing. And there's a lot more data on how to step up than there is on how to step down.
So are you doing this, giving inhaled corticosteroid with like long-acting?
So that would be a whole other lecture. So, I mean, I have a strong bias towards the type of inhaler that you use. Anybody that works in my office knows that I love the Glaxo product just because it's simple to use.
Right.
It doesn't fit with these guidelines. So that's already biased me against doing what they tell you to do. But nevertheless, in the right patient now, yes, I am trying to shift towards smart therapy. And specifically, I think it's very useful for those steps 2 or 3. And I mostly follow the GINA guidelines. I have not switched to the NHLBI guidelines. I think giving a separate short-acting bronchodilator and a separate inhaled steroid is stupid. And I think that using a regular inhaled LABA plus an as needed LABA might be too much for patients with milder disease. So I've been when I've been using smart therapy, I've been just giving them their Symbicort 80 and telling them to use it when they need it in the right patient. But I haven't been doing I haven't embraced these guidelines the way I should, or certainly what you should write on the tests.
And when are you looking at eosinophilia? I know this is separate from the guidelines. So, like, do you get an allergy workup on every single patient with asthma the first time you see them?
Pretty much, yes. So I definitely do unless they've been to an allergist, I do the
rest.
That rest. And while I'm doing it, I order a CBC.
Right.
Because I figured then I'll have it if I need it. So yeah, just about everybody. And I've been lobbying Harley to get an exhaled nitric oxide machine. I'm not that crazy about it. I don't think it's that great, but they were very exhaustive how they really studied this data. I mean, this was not just a bunch of guys giving their opinion. This was all the experts pouring through all the literature and grading it. And they came up with the conclusion that it's somewhat useful. So let's take them at their word. I think Andrew sent a message, but I don't know what he said.
So for those step 1 patients, you're not even prescribing SABA. You're just giving the 84.5 Symbicort.
Yes, I mean, most of them already have their SABA. I'm telling them to put it aside. Don't get rid of it yet, but just put it away. Just use their Symbicort. But call me if they need to use their Symbicort more than 6 times a day, and we'll do something else.
Dr. Illoway, have you noticed that people prefer one or the other? Like Symbicort versus SABA?
I mean, it's too early for me to give you any feedback on all this. But I personally think that once the studies of combination SABA ICSs are done, they're going to make a lot more sense than LABA ICSs. I mean, why do you want to bundle up LABAs? It doesn't make sense to me. So to me, using a SABA ICS as your reliever and then using some sort of long-acting ICS LABA as a controller might be the future, but we don't really have that data yet.
Well, I'm seeing patients have come to me on formoterol and ICS and another ICS.
Okay.
The primary care doctors are putting patients on these combinations.
Well, also, I mean, I won't mention a particular pulmonologist's name, but he shifts a lot. So by the time you get to see the patient in the hospital, they may have been on 7 or 8 different inhaler regimens and 6 or 7 different nebulizers. And there's just no way for them to keep that straight.
Right.
So a lot of patients end up on these combinations that are a little confusing. Like a lot of patients are on, Combivent or Duoneb plus Spirine. And there's really not a lot of data
Yeah.
about doing that.
Plus, you know what, I think when I order inhalers on patients, what dictates what I give them is what the insurance will cover.
Yes, probably more than anything,
Or
unfortunately.
anything, exactly.
I mean,
That's
Yeah.
the problem that we will have, I think, implementing guidelines like this. because-
Yeah. But this was so fellows can have answers for their board. So look at my pretest and see if you can get it right.
It's not just about the boards.
Well, yeah, it's about clinical care, yes, but I thought that they need to, these guidelines make good board questions, so I felt it was important to cover. I can
Yeah.
cover other stuff in the future if you want to. All right, any other questions?
No,
Thank you so much.
this is great.
Thank you so
Thank you.
much. It was great. Yeah,
Thank you,
thank
Dr.
you so much.
Really
Bye,
appreciate it.
guys.
All right.
Anna Maria.
Yep. Have a great night, everyone. Thanks, John.
Send your PowerPoint to Fiore.
Oh, he couldn't sign
He's
off.
off. Yeah.
I'll post the lecture
I'll
also.
email him.
Fiore, did you put it in OneDrive last time, or did you put it in OneDrive?
I put it in the OneDrive.
Okay, I'll upload it to OneDrive.
Okay,
And we can add those guidelines too. So
All
we have
right.
a comprehensive document.
bye.
Yeah. Okay, great. Thanks, guys.
Bye, thank you, Anna Maria.
Thank you.